You know, we see people younger and younger presenting. Oftentimes, marijuana is the first substance that's used. Oftentimes, that's followed in high school years with medications like Xanax, Valium, Percocet, things like that. And then it escalates. And then oftentimes, people don't realize how easy it is to become physically dependent on the opiates. And then after that, it becomes too expensive to continue to buy oxycodone. And people learn that heroin's less expensive. And I think it's important for people to understand that addiction is a disease, that a person with addiction has a brain that is essentially wired differently than someone without, and that they will respond to euphoria-producing substances in a way that is going to make them feel that they must use more. That can happen quickly, it can happen over time, but once it happens, it's essentially irreversible. And the treatment for addiction is treatment. There's not one way to treat it, but it's important that people get treatment, because without treatment, addiction's a chronic progressive illness, just like diabetes, just like hypertension. I think it's partly availability. I think that as physicians were encouraged to treat pain more in the 1990s, they became more liberal in prescribing. Pharmaceutical companies began to provide long-acting opiate medications to try and fill that need. There was little training or awareness on where that was going to lead. And I think that potent opioid medications became available that weren't so freely available before. You know, no one sits in that chair, and I see thousands of patients. No one sits in the chair you're sitting in, looks me in the eye, and says, why did I ever get sober? But a lot of people sit in that chair and say, why did I pick up when I was sober for 2 months or 2 years or 20 years and life was getting better? And they often pick up because they forget that underlying problem, that their brain is going to respond differently. And once they pick up that first substance, their brain tells them they have to use it again. It's on a level of survival to your brain. Our brains have a reward circuit so that when we're thirsty, we drink water, your brain says good. We're hungry, we eat, our brain says good. See our family smiling, our brain says good. That same circuitry gets owned by oxycodone or heroin or cocaine or alcohol, to the point where now your brain is saying, you have to have that. Forget water, forget food, forget a happy family, forget your work. If you don't have this, you're going to die. That's the message that your brain's getting in addiction. And people who don't have addiction don't understand that. If you hadn't had water in 3 days, and we were sitting in this office, and I put a bottle of water down, and I tell you that I'm going to leave the office for 3 hours, whatever you do, don't drink the water. When I come back, we're going to talk about how thirsty you are. Door closes, what are you going to do? You're going to drink the water. You'll deal with me in 3 hours. That's the message that the addicted patient is getting in active addiction. Well, I think the most common one is that you're changing one addiction for another. And I think that that really doesn't hold water, because someone who's taking methadone or Suboxone correctly, they're physically dependent on the medication, meaning that should they stop it, they'll have withdrawal symptoms. Just like someone who's taking pain medication properly for chronic pain will have withdrawal symptoms if they stop taking the medication. But they're not addicted to the medication because they're not getting high from it, they're not getting it illegally, they're not engaging in behaviors that are potentially life-threatening to get the medication. And hopefully they're active in other aspects of their recovery. So the two are not equal. That's one myth. I guess another one for methadone, people have a perception that methadone rots their bones, rots their teeth, and that really isn't true either. I think that methadone can be very dangerous when combined with other medications, other drugs, certainly any kind of other sedative, alcohol, the benzodiazepines like Xanax, Valium, Ativan. But taken properly, methadone, again, really can improve the quality of people's lives. It can be either. Suboxone can be used as a medicine to detoxify someone, in which case it's short-term. For people who go on maintenance, typically they need to be on maintenance for at least 6 months to a year with concurrent psychosocial treatment. So that means they're going to meetings, they're meeting with a therapist, They're going to outpatient programs because medication alone doesn't address all the issues of addiction. And when in time someone's ready to come off the medication, they need to have that psychosocial support ready for them when they come off. I can tell you that for every patient that I see for opiate detoxification, there's many patients who get turned away because their insurance companies will not pay for opiate detoxification alone. There are insurance companies that feel that opiate withdrawal is not a life-threatening emergency, so therefore they're not obligated to cover it. Overdose is a life-threatening emergency. Hepatitis is an emergency. HIV is an emergency. Going into Camden and being assaulted is an emergency, but they don't look at that. So I think there needs to be more available treatment. I think we also need to educate our colleagues around addiction much better, because I think that many physicians don't see this in their own practices. And if they did, I think they'd be much more willing to address it early on.
How can we do that? How can we?
Well, I think it's all the above. I mean, I think parents need to be aware that this is a huge problem. And I think parents need to be aware that people who are using drugs and alcohol are incredibly creative and good at covering that up. And if someone initially answers no to a question, you may need to look a little bit further. In terms of, within my own profession, I think physicians have a long way to go to learn about addiction and learn how to treat addiction. And that needs to start at the level of medical school. I think it's identification, early identification and treatment. Early identification and treatment. And treatment is not a one-time deal. In honesty, addiction is a chronic relapsing illness. That doesn't mean anyone has to relapse, but when someone does, it doesn't mean that they're done with treatment. It means that we need to try again. We need to modify that treatment. Somebody who is failing purely psychosocial treatment may need to go on medication-assisted treatment at that point. But the trick is to continue to engage people in treatment.